We continue the diastolic, we do not need in this case. Here we have the 4-chamber view, we have the 5-chamber view, and we have the various signals. Here we can measure, and it already measures the aortic valve because it's the signal, and both measurements are they are quite okay. So we are going for those measurements. We save the image and we take those measurements because they are definitely not bad. And we do see we have here up to 1.8 meters, and here also have all the gradients. So the max gradient is 10, and here 13 millimeters of mercury. Still all is normal. Now we go into the cavity, and we see here the gradients in the apical regions, the gradients midventricular, so there is a gradient, and more midventricular with more, or an optimized setting, we do see it's up to 1.5 meters per second, which is also not that relevant. So the 8 millimeters of mercury, that doesn't explain symptoms. So there is a gradient, but not a relevant gradient in the ventricle present as well. As we move to the LVOT, we do see there's a higher gradient. So that's also where we have to look at pathological gradients. So not measuring the aortic valve with the pulse wave Doppler, here we do see there's a somewhat dagger-shaped signal, and here I would go to measure also the LVOT gradient, and we are in the range of 10, 13, 15 millimeters of mercury probably. Here you also see the midventricular gradients, also dagger-shaped. The more midventricular it is, the steeper it is, and here you have a gradient as well. Both are definitely not relevant. When we use the stress test, you do see a little bit higher gradients, but still it's below 50 millimeters of mercury. Now measuring the diastolic function, it already shows us automatic measurements. This one, as there's an A wave shown, I wouldn't take here the same. The range around 1 meter with a reduced deceleration time makes per se sense. So therefore we are going to save this one and take it. So below 150 milliseconds is most likely showing elevated filling pressures, which you also see in the left atrium, in the left atrial strain. So it's definitely some fibrosis there. But when we compare it with the clinical status of the patient, he was telling us he's doing way better and he's, for his situation, fine. So I wouldn't overinterpret, but now we know how the measurements look like, and we can of course also use it. Then we continue with the E to E prime, and the E prime septal. I think it's a bit overestimated. I wouldn't use that. So here we have several heartbeats, and I would take one in the middle, so around 0.089 meters per second. And we go to the lateral, and here the measurement I think is absolutely fine. So in this range it is correct. So we take it, and then we have a E prime lateral, and the E to E prime, because we measured now several times, was around 10 to 11, which is a gray zone. Below 8 E to E prime ratio is most likely normal filling pressures. Above 14 is most likely elevated filling pressures. With atrial fibrillation it's a bit more difficult anyways, but so it's in a gray zone, but still elevated filling pressures. So left atrial pressures, and the same without mitral stenosis is the left ventricular and diastolic pressure. With again no stenosis is the pulmonary wedge pressure is probably elevated, but the patient doesn't have symptoms or relevant symptoms for him. So we also have to keep in mind, always keep in mind.